Good morning, everyone. Thank you for having us. We're really excited to be here. We're loving the theme of this conference, looking at hidden groups. Really interesting, really important for us to be able to look at things from other people's perspectives and see the different ways that cancer affects people. I'm Jo Colson, and this is my colleague Angie Bunn. We're working for the LGBT and Cancer project in Staffordshire. So this is a scoping project looking at the different ways that cancer affects people from LGBT communities, the barriers that prevents LGBT people from engaging with healthcare, and finding out where the gaps are in services and what can be done to improve things. I'll just explain, I'm sure everybody knows, but we're talking about lesbian, gay, bisexual and transgender people who were affected by cancer. It's an umbrella term, and actually they're quite different because lesbian, gay and bisexual people, that's about who you're attracted to, who you fancy, who you love, your sexual orientation. And the transgender side is quite different. That's about your gender identity and how you identify, either from the male side, the female side, or if you identify as neither, we call that non-binary. But we'll be talking more about those definitions a bit later. So we're based at Disability Solutions in Harts Hill. The project is working in partnership with Macmillan Cancer Support. We hope that when we've found out what the picture is for LGBT people in Staffordshire, that our findings will lead to service improvement and services to support people. We're not quite as far ahead as the previous presentation where services are in place and there's more progress. We do hope to be there. We hope that this work will contribute to things like that. So, why LGBT people and why cancer? Well, as we said at the introduction, I think it was Jane that said there's 2.5 million people living with cancer in the UK at the moment. Can anybody hazard a rough guess at how many of those might be from the LGBT community? Any ideas at all? Pardon? About a quarter? Any other ideas? More? Less? About three quarters. Well, we think that there's approximately 150,000 LGBT people affected by cancer in the UK. But we think that's a conservative estimate because there are government statistics that say that 6% of the population are from LGBT communities. We think that's conservative because that will depend on people self-declaring and being out and letting us know. So it's probably higher than that. So we're going to go through some of the headlines for why it's different for LGBT people. We often get this response, why LGBT? Cancer doesn't discriminate. But actually it can affect people from those communities very differently. And there are different risks. There are different reasons why uptake of screening is lower than mainstream communities. LGBT people are more likely to present later with more advanced symptoms of cancer. We know that there's loads of cancer-specific information out there, and Macmillan are brilliant for producing leaflets and information for every kind of cancer, every kind of side effect, every treatment, but nothing specifically aimed at lesbians or gays or bisexual or transgender people, where actually they can be affected very different and need to know different things from straight people. And then we'll be talking about discrimination. We are a progressive society, but unfortunately discrimination does still happen. And the use of hormones. For transgender people who are transitioning, hormones can affect the cancer risks, and there are other issues to consider there. That's something that Tara will be talking about. So I'm going to hand over to Angie to introduce herself and talk about the first headline.
My name's Angie. I am the engagement officer for the LGBT community within Stoke-on-Trent and Staffordshire. And what I've been looking at is I've been able to engage with the community, getting people to open up about what services they require from Macmillan and Cancer Support. We're looking at the LGBT lifestyle. It's saying that LGBT people are more likely to drink, to smoke and take recreational drugs than person that's not from the LGBT community. Not because of their lifestyle, because they go out in an evening, They make friends, that's how they make people like themselves, so therefore that's where all that becomes involved. If you can see there's a smoking prevalence there, a graph to show from 2014 that the gay community there have higher smoking. Again, that's recreational, and that's what a lot of gay people tend to do, to make friends somehow. Lesbians are more likely to be overweight. They're less likely to have a child before 30 and less likely to breastfeed. So therefore, those are all extra cancer risks and things like that because of their lifestyle, their health. Gay and bi men make up the highest number of sunbed users because they want to look their best when they go out. So they go out to sunbed for a few hours every week just to look so nice. So again, that's a higher risk of skin cancers in the bi and gay men community. Going on to the screening part now, 49% of lesbians and bi women aged 25 to 64 had attended cervical screening with the NHS at the recommended timescales, but compared to an estimated 73% of mainstream women, that's a very low uptake. But there's a reason for that. Some of the conversations I've had throughout many years with lots of my friends and working with the community now, these ladies are being told that they do not need a smear test because they've never had sex with a man, so they never follow it up again. I was aghast only 2 weeks ago when a very good friend of mine said to me, and she said, I can relate to that. She says, I was told, you've never been with a man? No, she said, I'm a lesbian. Well, actually, you're still a virgin, so you don't need a smear test. And that was only 2 weeks ago, so it's still there. This is going on. There's another story about screening, and it's a trans man who is also a wheelchair user, a permanent wheelchair user. When I was talking to him, and I said to him, you do realise the importance of going for your smear test? He says, I can't. He says, and you can't get there. What do you mean you can't get there? There is no hoist in my GP surgery to get me onto the bed to have a smear test. But they've never referred me to anywhere with a hoist to have that. So he hasn't had a smear test for over 14 years. So these are some of the stories that we're coming up against so soon into this project. Looking at other things as well, trans women will never be called in for prostate screening. Also, trans men and trans women will not be called in for breast screening. So, there's a bigger risk there of breast cancer, but the uptake of screening is lower than the mainstream because they're just not getting called in because of their gender status or because they've been told that they don't need to. And then there's the non-binary. Now, non-binary is going to be talked about a little bit later on about their inequalities within the cancer. So those are just some issues around screening that is a project we're going to be looking into. How can we change this? How can we make the LGBT community aware that they really need to ask for this screening, to stand up for themselves and say, yes, I am a lesbian, but I still need that. And if you think I don't need it, then can I speak to someone else that can make it happen? So that's what is a project that we're looking at and how we're going to implement our findings. You beat me to it, Joe. The next one we're looking at is information support. And there's not a lot of information out there that relates solely to same-sex relationships. We get heard from men who've been in the hospital with a male partner being asked many a time, is your wife coming to pick you up today? How does he answer that? Does he out himself? Or does he just say, well, it's my partner? And when a male walks in, they're quite shocked. So they're looking at information support that is specific for LGBT people. And there's a small saying here from Sophie, who's a cancer service user. And she said, I find myself having to think about the information that's there that fits with you and your life. You need to go back a few steps to work things out for yourself. It's trying to find out about things that would be very difficult to explain to a straight person. The information is there, but it doesn't always say your name. So in other words, there's information out there, but it doesn't fit to what she's thinking and what she's saying. So if you look there, there's lots of cancer information out there, and Matt Mellon are doing an absolutely fantastic job of putting out there these leaflets, and there's some over there on our information table. But so there's lots of cancer information, but there's nothing specific to the LGBT community at the moment. At the bottom there, you'll see supporting lesbian, gay, bisexual, transgender with cancer with the hands, male cancers and prostate cancers. They've been done by the LGBT community in Manchester. What I want from this project is to have that type of information with Staffordshire on it. I want it to be all singing, all dancing, the same as everybody else across the country, but with Staffordshire on it as well, that we're here to support, that we're here to help, and that we're here to make sure that you've got the information that you need to help you through with your cancer and the support that you're going to need. I'm going to hand back to Joe now, who's going to talk more about discrimination, so thank you.
Yeah, so I said we are a progressive society, but unfortunately discrimination does still happen. Sometimes it's inadvertent. Sometimes the issue of perceived discrimination is just as big and just as important for LGBT people, even when it doesn't happen. An example that we come across for this is we've heard a few times from LGBT people that the doctor was religious and didn't accept their partner, their same-sex partner, as the partner. This was the story that came up last time we were in Manchester. And it was the lesbian who was telling us that she just felt that that trust relationship that she had with the doctor is so fragile that when she realised that she was with a doctor for whom homosexuality was illegal in their country, it just broke down that trust relationship. I mean, obviously that's not allowed to affect the doctor's practice, it's not allowed to affect how they treat the patient in any way, but just the knowledge and the perception that that's the case can affect those relationships. And it can be more overt and more blatant than that. We've got some quite horrifying stats there. 1 in 4, a quarter of patient-facing staff have heard their colleagues making homophobic remarks. 1 in 5 transphobic remarks. And then 3 in 5 staff responsible for patient care don't believe that sexual orientation is relevant to health care, which is something we hear time and time again. I don't see sexuality, I don't care if you're gay, lesbian, straight, yellow, black, pink, we treat everybody the same here. And what we're saying is it's not right to treat everybody the same. We're not all the same. You need to treat people differently to make things equal. And as Angie touched on, people aren't always comfortable to come out to the health professionals for these reasons. So it's a third of gay and bi men who haven't been able to come out to their healthcare professionals. Doctors assume that they're straight because the NHS assumes that everyone is straight. It's a heteronormative thing. And actually they should be coming out because the treatments and the effects can be very different for them. For gay and bisexual men affected by prostate cancer, the results of the sexual dysfunction that they experience afterwards, the treatments can be very different. So the doctors do need to know that, and it can make a difference to their cancer journey. We've got some figures here of the LGBT hate crime statistics locally for Staffordshire. So the top set are the North Staffordshire figures and the bottom South Staffordshire. They're a little bit difficult to interpret because they both record them in different ways. So Challenge North staffs record them by victims and incidents, and South staffs just record the number of victims, so we don't know how many incidents there were. But the takeaway thing from this, if you look at the top set of statistics, is that from April to August, just in those first few months of this year, there have been 80 incidents of hate crime compared to 12 overall altogether last year. So it's a huge increase this year. Kirsty and I were talking about it earlier, and we don't think it's as drastic as it sounds. We hope that it means that more people are comfortable reporting incidents rather than such a massive rise. Okay. So data monitoring. This is a bit dry, so we think it's really important that we're monitoring the statistics so that we know how many people are lesbian, gay and transgender. Because like it says there, if you're not counted, you don't count. And we can't make accurate assessments or predictions or anything like that unless we know how many people we're dealing with. So, for example, to make sure that we send screening letters to the correct patients, we need to have those details on file. A trans man will no longer be called up for smear tests, and yet if they've still got a cervix, they still need to get smear tested. We need to make sure that the patients we're treating are representative of the community and that we're reaching all the people that we should. Nobody's being left out. We can't know that unless we're monitoring the patients that we see. We need to make sure the clinicians have as much information as possible so that they can make these connections. We were talking about a trans woman presenting to the GP saying she needs to go to the toilet all the time and so on, and the doctor not making the link that maybe a PSA test might be in order, it could be prostate cancer, because the GP just sees a woman, female patient and doesn't make that connection. And to discover the prevalence rate of conditions within particular groups, so we know how different groups are affected at different rates by different cancers. And it's important because it's the law. I expect probably a few people are familiar with the 2010 Equality Act, but it's a legal obligation to show that you're showing due regard to people from those protected groups. And we were saying earlier, if you're monitoring one set from that group, you have to show that you're monitoring all of them. Okay, and so monitoring them can help to tackle inequality and increase access to services. What we find is that people will try and they'll make an effort and they'll do what they can. They won't always necessarily use the latest recommended questions to monitor, so they'll perhaps muddle up sexual orientation and gender status. And it's not always consistent. Some of the resistance we meet is because people say, well, it's uncomfortable to ask those questions. We don't want people to think that we're stereotyping or showing any kind of prejudice. But actually, these are the reasons why it is really important. So government health has identified sexual orientation monitoring as a priority. We need to improve the way that we monitor these things. Just a couple of quotes that illustrate that. Having a patient's sexual orientation on file makes everything faster, and it means we don't dance around it at the start of the consultation. If it's part of the formal procedure, that it's one of the questions that is asked, then there shouldn't be any awkwardness or any uncomfortableness. It's not about stereotyping, but about bringing things to the forefront of my mind, such as signposting specific services. You need that information to make sure that you're passing people on to the right places. And the CQC guidelines, this isn't a legal thing, but this is recommendations. So just to make sure people get the appropriate information and treatment, and that due regard is shown to sexual orientation. One of the major issues we've come up against, and something that comes up time and time again, is the need for training for healthcare professionals. We find again that that's inconsistent. It's sometimes touched on. People say, oh, I've had equality and diversity training. I covered that 5 years ago. It's perhaps not up to date. The graph you can see there, which is a bit small, is from Stoke Pride this year. We carried out a survey and we were asking the LGBT people at Stoke Pride who had been affected by cancer what they thought was missing and what they thought the priority should be. And the highest one was LGBT awareness training for healthcare professionals. And some examples of why they thought that was needed. These were some of the comments that people made to us. They'd experienced having their female partner not accepted as an emergency contact. Somebody talked about having had counselling after their mother's death, and the counsellor was Catholic and clearly anti-gay and clearly had a problem, so that counselling had to end. Healthcare professionals getting embarrassed with same-sex couples and being shocked when a same-sex partner was revealed. So we think that more training, more awareness, bringing it to the forefront of professionals' minds and just making it part of the consultation, part of the signposting would really help things. Okay. going to hand over to Tara.
Hi everybody, my name's Tara Hewitt. I'm the Equality, Diversity and Inclusion Lead for University Hospital South Manchester. One of the reasons Angie and Joe asked me to come along is because we work together as part of the Manchester LGBT Cancer Support Alliance, and we hosted the largest ever conference in the UK on trans cancer inequalities, which was opened by our medical director John Crampton earlier this year, which spent a full day with health professionals, trans charities, trans people, looking at the specific inequalities that trans people experience. My background also is that I'm a freelance diversity consultant and have worked across various NHS trusts in the UK, supporting them looking at health inequalities. I lecture health and social work students at different universities, and I've worked across the prison and forensic hospital estates, looking at equality and inclusion, both with staff and directly with patients and prisoners, so there's a broad range of experience there. We've also, as a hospital, co-founded the Trans Equality Legal Initiative, which is in partnership with Linklater Solicitors, Garden Court Chambers, Action for Trans Health and Wipe Out Transphobia, specifically looking at supporting trans people's rights in the UK to understand that they have the right to services to be designed to meet their needs. And we've talked very much about that for other communities and making sure that trans people are aware that just because there is a lower level of knowledge, that doesn't mean that they don't have the right to healthcare that meets their needs, and actually make sure that they're supported and receive the care that everybody else should receive. Move it forward. Thank you. So I'm just going to cover looking a little bit about diverse identities, because I think when we talk about trans people, we don't always know what we're talking about. Some people have different perceptions about what we mean when we say trans people, and trans is an umbrella term, so we're going to explore some of those different identities. We're going to look at intersectionality, and I think it's really good that we're looking at other identities as part of this work, but we're also looking at the impact being in different social circumstances, being in prison, because actually all of those things interact. They're not in isolation. You're not just trans, you're not just gay, you don't just have a learning disability, you're not just a prisoner. Actually, all of those things, when come together, can make people have different experiences, different levels of privilege, and actually receive different levels of care, even within those same communities. So it's important that we look at those together. I'm going to briefly look at some of the social inequalities that we've already touched on and how that's specific to trans people. Looking at why trans people might have barriers into healthcare because of stigma and historic experiences. That healthcare is about all healthcare and not just about people being trans. And then finally looking at what some of the very specific healthcare issues that trans people might face. So, trans as an umbrella term. Firstly, if we look at the trans community as a whole, how many trans people in their lifetime do you think will be affected by cancer? So in their whole lifetime, how many trans people in the UK do you think will be affected by cancer? Who wants to have a guess? As a number. Do you have a number? Have a big figure? 50,000, did you say? Not percents. So this is numbers of people in the UK. How many numbers of people in the trans people will be affected by cancer in their lifetime? It's also making you think of how many trans people there are, so. 50,000. Does anyone think it's higher than 50,000? Put your hand up if you think it's higher. Higher? Okay. Do we think it's 100,000 or higher or lower? Higher than 100,000? Put your hands up if it's higher than 100 or lower than 100,000. Put your hand up. So I think roughly people think it's a bit lower. 300,000 trans people in their lifetime will be affected by cancer. So when we're talking about trans issues, sometimes people think we're talking about a very small number of people, and actually that's a big number of people actually needing access to health services that at the moment aren't always designed to meet their needs. There's 600,000 trans people in the UK. Most of the information and support says that trans people are more likely to have cancer, they're more likely to die of cancer, they're more likely to be diagnosed late at cancer, and that's what we're going to look at some of those barriers as we go through the presentation. So trans is an umbrella term. Trans is a term to talk about a range of different people, and historically we've used terms such as transsexual, which isn't used very much now, but it tends to talk about people that have permanently transitioned from one gender binary to another gender binary. So you talk about people who've transitioned from being male to female, but it's nothing to do with surgery. It isn't to do with medical care. Often when I talk to people about being trans, people almost legitimize it by saying, well, it's about surgery and about what medical care they've accessed. But simply saying that they are them, and this is how they're going to live their life permanently. So that's where that sexual generally comes from. Drag king and drag queen are people that dress up in a very over-stereotypical way of a particular gender for entertainment purposes. We've all heard of drag queens, but drag kings tend to be an area that we often don't talk about, which is just the opposite way around, and it's becoming more mainstream. Cross-dressing, there's two types of cross-dressing. So you've got people that fetishistically cross-dress, so they wear clothing to get a sexual desire out of that clothing of the opposite gender. It generally tends to be associated with men wearing women's underwear and women's clothing. I don't know any women that wear boxer shorts and find that sexually arousing. But if you do, that's cool, because actually we're all very diverse and we have diverse sexual appetites as well. And actually, one of the things that I find quite challenging is when people stigmatise different identities and make judgments about them because of where they are. And actually, as long as somebody is happy and living their life the way they want to and expressing themselves, why should any of us make a judgment about that? Transvestite, again, is quite an older term, but is still used by some people to talk about themselves. It generally means somebody it's more than clothing, it's going out and expressing themselves in a way. It's the social element, being interacted with in a particular different gender type to themselves. So normally somebody might be identified as male, but at a weekend or part-time might like to go out and be viewed as Sarah or viewed in a female identity. They don't view themselves as that. It's just an expression of part of who they are rather than their whole identity. And often people use different language to talk about now, but it's a historic word that you might still hear and use. Non-binary and genderqueer. So the non-binary community is much bigger than many people actually realise. So the amount of people that don't want to use pronouns such as she or he, much rather use the terms like they, sie, their, depends, there's different pronouns that people like to use. It's important to ask somebody how they want to be interacted with, and don't just make assumptions that you know the words that somebody wants to talk about themselves. I generally talk about everybody in the term they, or use their name until someone's told me and I know a little bit more about somebody, rather than making assumptions. And I think a big area is when you're on the telephone, and if you run a service that uses telephone, when people automatically say sir or madam without actually getting to know the person that they're speaking to, and that can have a big impact on all trans people. But if you don't use any of those terms and actually use a different pronoun, then actually it's going to have a particular impact on you. So we need to make sure that we're getting those issues right. Genderqueer and queer identities. Many people actually use the term genderqueer, and it tends to mean, why should we label people? If gender is really personal to us, why should you make a judgment about what my gender is based on what I'm wearing, how I talk about myself, what length my hair is? You could spend a whole session exploring what genderqueer and queer identities are, but it's been aware that they exist. A lot of groups are now LGBTQ that you might see, and actually we need to be using that language if we're going to make people feel comfortable in our services. So we could spend all day on those identities. If you want to come and have a chat at lunchtime, I'm more than happy to come and talk about them more. So I already mentioned intersectionality. I think it's important that we understand that actually many of us have different levels of privilege, actually engage with the world differently. So although I'm trans, bisexual, I'm also middle class, I'm not black, I'm white, and actually my networks may be different from somebody that is maybe homeless, is maybe suffering racism, and maybe has a learning disability and experience additional barriers to those that I might face, but there'll be barriers that I face simply by being trans, even though I have those other privileges. So actually that interrelationship is really important. Don't just stereotype and pigeonhole somebody in one of the protected characteristics. So we said already about social inequalities, but specifically for trans people, 20% of trans people are unemployed or not in work, and we know that that leads to a greater risk of cancer if we look generically in the population. Trans people are more likely to be homeless, so 25% of youth homeless in the UK are LGBT, so a big chunk of those are trans. Trans people can often experience isolation and receive less family support. So we know that social isolation, so we're talking about drinking and smoking, one of the reasons, other than the fact that people enjoy doing those things, like everybody, whether you're LGBT or not, is if you're socially isolated and don't have a lot of support, often you turn to smoking and drinking just to get you through the day. And that's increasing people's risks because society is leaving these people behind and actually leading them into that isolation. Trans people have higher rates, so said smoking. A significant number of trans people are sex workers and experience sexual exploitation in the UK, again, which can mean that they're not as open with health professionals because they're worrying about stigma that sex workers experience. And actually, there's a big number of trans people that work in the sex industry but won't be open or feel that they can't fully engage with health professionals because of the judgments that people are still making. And trans people have higher rates of secondary mental health issues. And again, we know people with mental health issues are more likely to be diagnosed later with cancer diagnoses and receive poorer qualities of treatment. So 80% of trans people self-harm, 40% attempt suicide. They suffer whole sorts of different barriers in engaging with those services. So, stigma and historic experience. So one of the things when I talk to people, they go, well, why wouldn't trans people access a fantastic health service that's been rated as good or as outstanding, or as a hospital like our hospital in South Manchester, where we're looking to do some of this, to do a lot of this work, is because of past experiences. I can speak for myself that although I work in the NHS and I've speak in the media and I've done loads around this agenda, and I'm quite confident in advocating for myself, it takes a lot of energy for me to step up to go to a GP because of the amount of negative experiences I've constantly had within GP services. I've been sat next to a GP where they've rang through to reception and said, I've got a man sat here, can you get me his records? Just really, really inappropriate language. I had a nurse who was taking my blood pressure, who I transitioned about 10 years ago, but so 10 years later, I've still got somebody saying to me, so how far through the transition are you? I'd just gone for my blood pressure check. What on earth had that got to do with the appointment that I was in there for? If you look at the hashtag #transdocfail on Twitter, you can see thousands and thousands of examples of trans people talking about their experiences. And that's what's on people's minds. So unless you do something to overcome that past experience and show that services have changed, and you visibly shout about it and show that you've thought about trans people, you're not going to actually get people to come through the door in the first place, or they're only going to go to the GP at the very last minute. And if they're not going to the GP when they've got symptoms, they're going to be diagnosed later, and that's going to lead to people dying more of cancer, which we're seeing at the moment. Poor language we've mentioned already, so people using inappropriate pronouns. I've been in clinical consultations where they'll revert to using different pronouns in private than they do with the person in person. So you've got a trans woman and they'll be talking about her as her and she in person, but when they go into their MDT meeting, they'll be talking about that person as he. Now, why would we be changing our pronouns in that space? It would be like saying we should insult somebody when they're not there, because it doesn't matter, because they won't hear it. Because that's exactly what you're doing if you're not using the language appropriate to those patients. Lack engagement with the community. So one of the things that we've been trying to work with Macmillan around is engaging with specific trans people who have cancer. But if you haven't built up a relationship with the entire trans community first, it's going to be very difficult to find those trans people because the community itself is disengaged from health services. So you've got to actually build a foundation of engagement with the whole LGBT community before you start looking for very specific people within that. Lack of inclusion in information that reflects the lives of LGBT and T people, and not just as an added extra. So that's both about, if you separate your guides into male and female, you're never going to make it trans inclusive. Actually, you can have sections that talk about different identities, but make sure that you don't come up with two separate guides. Because if you are, you're going to find it very difficult to make trans people feel that they're included within that information. But also recognising that LGBT people have diverse lives like everybody else, and that just adding that we recognise LGBT people and are not changing any of the content isn't making it inclusive to LGBT people. We need to start talking about real people's lives, their real experiences, and how things can practically help and support them. And I said inappropriate curiosity and expectations for trans people to educate. I remember doing some training with a group of surgeons and surgical nurses, and them telling me that they expected trans people as part of their care off a gender identity clinic to be supported to educate all health professionals in the UK in any appointment that they go into. They should be prepared to be able to educate anybody. Now, I don't know any other group that is expected to deliver the education to the health professional whilst they're going in for an appointment for what might be a very sensitive issue, something that's a big traumatic experience, and then they're going, but you should also make that health professional feel comfortable whilst you're in that space. And that's the language that we're still using when we're talking about trans people. Healthcare, not just gender care. So again, when we're looking at this area of work, a lot of clinicians think all of the health issues for trans people are about accessing a gender identity clinic. Now, out of that 600,000 trans people in the UK, the majority will never step foot in a gender identity clinic or a specialist gender service. And even those of us who have accessed gender-specific medicine, it was for a year, 2 years of our life. Most of the healthcare that we engage with is the same healthcare that everybody else engages with. And actually nobody's spending the time and effort to make that healthcare inclusive. If you go to a trans health conference, it's all about gender identity clinics and specialist gender services. They're not talking about people dying of cancer, respiratory health issues, and other health issues, and mental health services, and how we can make sure trans people are including in those. And that's what I want to hear people talking about, all healthcare, not just gender identity specialist healthcare. So trans-specific health needs. So this is about some of the real technical information that trans people can have very specific needs that clinical staff and doctors need to be able to understand. So depending on someone's surgical outcome from surgery, if they've had surgery as a trans person, trans women, their urethra can sometimes be pointing in a different direction after surgery, which can lead to a rupture of the urethra when you're inserting a catheter, if you're actually using a catheter. Now, lots of clinicians won't know that, and actually it can lead to somebody's urethra rupturing. Now, it's a really technical piece of information that you will not learn unless you go to some training and you have some training on that. So that's a risk of potential harm that people experience. Hormones, so we've mentioned already that there's very limited research on actually the interrelationship between estrogen and hormones that trans people may take, and breast cancers and other types of cancer. And the World Health Organization has said that this is an area that needs investment and needs people to be looking at that research the same way, because we know that hormone can have that impact on different cancers, particularly within women. Body type. So trans people can talk about their bodies in very different ways and can have very diverse bodies. So often when we talk about people who are assigned male at birth, who might have transitioned and identify as women, people have an assumption about what their body type looks like. So when we're looking at guides that are inclusive, they'll go, well, trans women will have a vagina. Well, actually, not all women have a vagina. And I know that can be a very bold statement to make, but we need to start making it and actually being clear that not all men will have a penis and not all women will have a vagina, that people have different body types and we need to engage with the person about their body type. And actually, if you're doing an intimate examination, you need to understand that some people might be more uncomfortable with intimate examinations, not just trans people, actually anybody, for all sorts of different reasons. So if we can make it part of actually just the processes the dignity that we're delivering in healthcare, that we understand that people might be uncomfortable in certain circumstances, and that we're making sure that we're engaging with them and delivering that person-centered care, then actually we solve some of those issues. Language that we use about their body, so some trans people use the word cock to talk about their clitoris, and some people use the word clitoris to talk about their penis. And so again, if you're working in sexual health or cancers which are involving some parts of the body, actually asking the person you're working with what language they use to talk about their body, so you can reflect that language and make them feel comfortable. You don't have to understand why people do that. You can, if you want to, we can come and have loads of time and conversations having that, but just understand that makes somebody feel comfortable, and that's what we're there to do. And if we know it makes people feel comfortable, then we should do it, and it's a really simple thing to do. Additional wellbeing support. So if you've gone through your whole life actually fighting to live as who you are, and then actually had surgery, you've had breasts grow as a trans woman, and then you've had to have a mastectomy, again, that's going to have an additional impact on you than it will on anybody. Again, it's a traumatic experience for anybody in that situation, but understanding the additional mental health or the different mental health impact that might have somebody who's already had gender dysphoria and different experiences about their relationship with their gender, and wider health needs. If trans people are never going to their GP and are actually rarely coming into contact with health services, then actually if you're having a health contact, make the most of it. Talk about a whole range of other health issues with that person, not just about their cancer, because actually they might not have engaged with other health services, and that might be a really great opportunity to do that. And just any questions, we're happy to take them before we go.
Any questions from anybody? Always approach us. Okay, thanks for everybody's time.